So welcome to today's Sharing Mental Health Notes with Patients webinar. My name is Liz Salmi. I'm the Senior Strategist of Research Dissemination for OpenNotes, and I'll be introducing you to the cast of characters along the way. And we have fantastic presenters, and I'm excited for you to learn from them. Welcome to this webinar, Sharing Mental Health Notes with Patients, featuring our special guest presenters, Dr. Stephen Dobsha from the VA Healthcare System in Portland, Oregon, and the Oregon Health and Science University, as well as with Stephen O'Neill, who's the mental health liaison for OpenNotes and faculty at the Center for Bioethics at Harvard Medical School. Some background on OpenNotes for you, since it's your first, many of you, it's your first time hanging out with us. You should know OpenNotes is not a product or a software. OpenNotes is a research team based at Beth Israel Deaconess Medical Center in Boston. As researchers, we've been studying the effects of shared clinical notes on patients and care partners and clinicians for over 10 years. OpenNotes is more than me. I'm just one person on the team. OpenNotes works with research collaborators around the country as well as overseas to foster and evaluate the spread and implementation of shared clinical notes. And when visit notes are shared with patients, we call those open notes. We are funded entirely by federal and philanthropic gifts and grants. OpenNotes across North America. As of today, we are aware of more than 260 health systems that have adopted an OpenNotes approach to clinician-patient communication by sharing ambulatory visit notes with their patients via secure online patient portals, which those portals are primarily tied to your existing electronic health records. Before we dive in, I want to quickly highlight a new public policy that should be on your radar or is likely on your radar and why you're showing up to this webinar today. Starting April 5th of this year, a new federal rule will require U.S. healthcare providers to give patients access to all the information in their electronic medical records. The information sharing rule emerged from the bipartisan 21st Century Cures Act that was passed by Congress in 2016. This rule mandates that patients will be able to access their test results, medication lists, referral information, and clinical notes rapidly and conveniently through those electronic health records. Today's webinar is not about this 1,000-page rule, but we highlight that nearly all notes must be shared with patients. And there are some exceptions to this rule. For example, if a clinician believes that by blocking information, not sharing some information with a patient, you are substantially reducing the risk of harm to a patient or another person. I think that's on the next slide, Amanda. By the way, Amanda runs the slides and she's amazing. So there are some exceptions to that rule. And I say that because there's a good chance our presenters today may reference the Cures Act and this rule and information sharing and information blocking. All right, so thank you for listening to that long preamble. Let's dive into today's important discussion about sharing mental health notes with patients. Our first presenter is amazing. Dr. Stephen Dobsha is the director of the Center to Improve Veteran Involvement in Care at the VA Healthcare System in Portland, Oregon. He is also a professor of psychiatry at Oregon Health and Science University. We are so lucky to have him share his research and information that he's been discovering over the last few years around OpenNotes and mental health. I'm handing it over to you, Dr. Dobsha. Thank you.
All right, thank you, Liz. I'm going to be speaking about really about the results that came out of a project that we did a few years ago in the VA health system. The project was supported through VA research funding, and I'll just mention that neither Steve nor myself have significant conflicts. So to give a little bit of background, the VA has had an electronic health portal called My Healthy Vet really for probably almost 15 years now. But in 2013, so 8 years ago, authenticated users of My Healthy Vet gained the ability to access all of their progress notes. It's essentially called VA OpenNotes, and interestingly and different from a number of other organizations, there is no provision to block notes, including mental health notes. And we've never really had that. It just kind of all happened in January of 2013. Um, and so it's been an interesting course. And just to give some sense of context, about 2.5 million VA users have now either viewed or downloaded their notes through the blue button that's available in my. I'm not going to spend a lot of time on OpenNotes in general, but just wanted to give a little bit of background. So there was a hallmark study. Tom Delbanco, Jan Walker, and others completed a study published in 2012 of 3 hospitals involving over 100 primary care providers and almost 14,000 patients. And in that study, they followed both providers and patients for up to 19 months and essentially found that almost all of the patients reported that OpenNotes helped them feel more in control of their care. A large number reported increased medication adherence. And among the primary care group, a majority reported that OpenNotes strengthened the relationships with their patients. And this included enhanced trust through transparency, communication, and shared decision making. And in contrast to worries, the primary care providers reported really more modest effects on practice activities and workflows. Jan Walker did a 7-year follow-up study with those cohorts and found that those positive patient experiences continued. Also found, though, that fewer than half of the clinicians and patients were discussing notes during visits. And this is a theme that's come up a few times in our projects as well. So we don't, in contrast, and I'll just say that there's been a number of other studies on use of OpenNotes, generally showing positive impacts. But we don't know nearly as much about OpenNotes use in the context of mental health. Mental health notes typically contain more details, more sensitive types of information, and that may be a big factor. For example, so there may be documentation of trauma. There may be certain diagnoses that carry stigma and that clinicians are often uncomfortable talking to their patients about, such as personality disorders. People may have concerns about the risk for violent behaviors. There's questions about what do you do when a patient has delusions and may be in the office for a different reason than you think they're in the office. And then there also may be private information about other individuals who are close to the patient. And we have learned that it's not always just the patient who views their notes through OpenNotes. It may be a family member. So, before I move on to our study, I will mention there were a number of early studies done on paper mental health notes. Those studies were done in the late 1970s into the 1990s. Probably the majority were on inpatients and with smaller samples, case studies type of things. But basically finding that patients who had mental health conditions did report better understanding of their problems. Most felt comfortable. Even if they felt uncomfortable, they preferred to be able to see the notes. But there were other downsides. So they did find offensive and stigmatizing language, sometimes caused some upset or created more pessimism. I have all these references if anybody ever wants to dig into them. They're pretty interesting. So our study, again, a VA-funded study, really had 2 main goals. One was to understand veteran and clinician perspectives and experiences with OpenNotes in mental health care. And then we sought to use that information to develop and then evaluate web-based courses. So we created one course for clinicians and one for veterans. And those courses were designed to minimize unintended negative consequences of OpenNotes, but also potentially optimize collaboration and communication through OpenNotes. I can't mention all my colleagues and consultants and people who helped, but just to say I've listed many of them here and want to thank them all. So how do VA patients who receive mental health care feel about OpenNotes? So one part of our study is that we had 28 interviews with veterans. These veterans had all read at least one of their notes through VA's Blue Button. Several key themes emerged. Well, probably the biggest had to do with trust. Trust was a big issue was found to be very critical to the therapeutic relationship in general, and the veterans tied reading their notes to either being able to strengthen or strain trust in clinicians. And probably if a patient has a good relationship with a clinician to begin with, open notes, being able to read notes may not have a huge impact. Similarly, if the patient doesn't have any trust for the clinician whatsoever, I'm not sure that mental health, reading their notes is going to make much of a difference. But there was definitely when you have a newer patient, when that relationship is a little less clear, it seemed like reading notes was important. I'm not going to read all these quotes. I'm going to say just a few. So one of them, a veteran said, "Did the clinician actually listen to me? It seemed like a very different person written about in the notes at times." And a more positive one, "I like the way that my clinician puts them in because he's very blunt and honest. He pretty much says exactly what I've said. And what I really like about it is that he also puts in there what we've talked about and what I said I would do." And that's a theme we did here, is that it's important that notes have at least a little bit of information about what happened in the session today. Many notes are boilerplate. There are lots of cut and paste going on. I read a lot of notes during my research, and it's kind of disappointing. It doesn't take that long to put in a couple of things about what happened in today's session. So we also did some longitudinal surveys with veterans. 359 veterans participated in that. I'm not going to go through all these other than to highlight that our sample really reflected Oregon's veteran population, older, white, male. Our group was also probably slightly better educated, and almost 2/3 had PTSD and almost 2/3 had depression. So what did we find? These are some data that came out of the baseline surveys that we did. Next slide. So what we see is a number of positive things that the veterans have reported. Most are reporting that they were very supportive of mental health notes being available online. They felt it was very important to have access to their personal health information through the blue button, very likely to be able to understand mental health notes. And actually, most felt that it was likely for the notes to accurately describe what happened in their appointments. So this is a group that had at least a little bit of experience with open notes. Now, the flip side is, and one of the main concerns has to do with causing stress or worry. So we only found that less than 10% found that reading their notes often or always caused stress or worry. The number who reported some upset was larger. Probably 26% reported that sometimes they had been upset or worried about what was in their notes. But very few really reported that this was a pretty important problem. So switching to clinicians now, how do clinicians feel about open notes? Again, we did another set of qualitative interviews with 28 clinicians. And there were also a number of interesting themes, or what we thought were interesting, that emerged. So clinicians expressed concern that by reading notes, patients would negatively misinterpret their notation or feel judged or stigmatized. Quote, "There's lots of technical information that's included in notes that could be scary or off-putting or confusing without context or someone to help explain it." Again, this is a quote from one of the clinicians. Clinicians also express strong desires to protect patients from harms that might result from reading note. My interpretation of this is that clinicians and our healthcare systems are still very much caught up in the biomedical model. And in the biomedical model, individual clinicians are held responsible for bad outcomes, as opposed to a more patient-centered type of framework where patients and clinicians may both share accountability if things don't go well. Next slide. Another theme was that some clinicians felt that the notes had potential to undo the work that they'd been putting in to develop a therapeutic relationship. And this came up in the context of people who might be clinicians working with people who had psychotic conditions. Clinicians, on the other hand, this is the positive, felt that despite their discomfort, open notes probably helps keep them accountable, ultimately resulting in improved care documentation. We also had quantitative findings from the clinicians. Now some of this is also from baseline data. I'm going to start with some of the negatives. So this is really earlier on. This is from about early 2015. So open notes had been in, already been active in the VA, although not very many patients were using it then. But at that time, almost half of our clinicians felt that they would be somewhat to very pleased if mental health open notes were discontinued. And some 40% were worried that patients would be confused or might disagree or find errors in the notes. And about a third worried about patients worrying. On the other hand, about 41% were very to extremely supportive of providing online notes in general, and about 30% felt that mental health notes should be available to patients online. That's very to extremely supportive. About a quarter reported that they often or always discuss in advance what's contained in notes to be written. And about 11% reported that they'd see more trust from their patients. So I wanted to focus just for a minute on clinician experiences of negative events. And so we asked clinicians if they were aware of any specific negative consequences that had occurred in the prior 3 months. And these are the baseline data. And it was a relatively small percent, about less than 20% reported that they'd seen a negative consequence with one of their patients. Most of the time when that happened, it had to do with being upset or disagreeing with a diagnosis. And another one patient was concerned about effects of compensation or insurance. And in the VA medical records are used to make VA disability determination decisions. And so this is of high priority to our veterans. So that's important to keep in mind about the negative consequences. We did have 2 out of 27 report that there may have been violent ideation expressed in response to reading notes. Unfortunately, I don't have any more information about that, and I don't know of other researchers who have really been able to dive into that. It's extremely hard to gather data from the VA system on an event like that. And I will say that the experiences over time from these clinicians, so we surveyed them multiple times over 12 months, and that proportion that we're reporting some type of a negative experience stayed about the same. So I just wanted to say there are a couple, where it says additional study, we have some work done by Chimowitz and Dr. O'Neill, my colleague today, also done psychotherapy notes. And basically what this shows is that the people have found similar findings. What we see is that patients find notes to be helpful. There's some evidence that they don't talk to their clinicians about them. And there is occasional times when people report some upset. So to summarize what we're finding with veterans, veterans find benefit. A minority note more stress or worry. As I noted from the qualitative work, open notes can either enhance or diminish trust. We did have a sub-study where veterans did say that they often weren't talking to their clinicians about reading the notes unless they were asked. And that seems to be, again, a common theme. Unless you're talking about open notes with your patients and orienting them to the notes, their availability, they may not talk to you about them. And the potential benefits may be lost, or at least some of those benefits. We did find from our qualitative work that veterans who frequently were upset just chose not to read their notes. So that might be somewhat reassuring that if you have a patient you're working with that's getting frequently upset, maybe it's not in their best interest to be reading notes. One other thing, finding I wanted to mention is that we did find that patients with PTSD were more likely to report negative emotional responses to their notes. On the other hand, they were twice as likely to read their notes, and they reported increased patient alliance from reading notes. So this is definitely an area I think worthy of more research, really to kind of explore what's happening within the PTSD group. And just to, again, summarize the findings from clinicians, we do see that clinicians have a wide range of opinions and ambivalence about open notes. I don't think that's changed too much. I think clinicians have gotten more used to it, but in the VA, it's kind of the way it is. But that ambivalence continues. And And what I see is that people often like the idea. Most clinicians kind of like the idea, but they worry about particular relationships, particular circumstances where they may not want to share notes. Um, I think I've said these other things, so let's keep going. So a couple other things. We did produce training programs. This is an active training program, and right now, I suspect you would be able to access it if you tried. Um, but aside from that, I'm happy to share detailed outlines of our program information, both for clinicians and for veterans. If anybody wants to send me an email or reach out to me, I'm happy to provide that information. So I can't go into the training program, and I want to be sure and turn things over to Steve in a minute, but one of the frameworks that we use to guide uh, how to write notes was the clear strategy. And so I thought I'd walk through that for just a minute. So connect, the C in clear refers to connect, which really has to do with connecting the visit to the notes. And the idea is to provide transparency in the visit and generally try not to have something that shows up in the note that wasn't discussed in the visit. I think if you're worried about potential negative consequences, if you can do just that, not to try to put new stuff in, then I think you can avoid some potential negative problems. Um, Language is important. It's important to be thoughtful about acronyms, not so much acronyms, but I think stigmatizing language, judgmental language. For example, don't you don't want to call a patient a schizophrenic. You want to talk about an individual with schizophrenia. I mean, there are some subtle things you can do. And if you, I think Steve is going to talk about pretend the patient's looking over your shoulder. And I think or I saw that somewhere, but that's a really good rule of thumb. And just be thoughtful about your language. I think you want to encourage provide encouragement through by documenting at least something about patient strengths or progress. Again, it doesn't hurt. It can take a sentence in a note, but I think that can really help. Being mindful of your audience. So one of the biggest concerns I have is how much detail mental health clinicians are often putting into notes. And it's interesting because on one hand, many of our patients say they like the detail, they want the detail. On the other hand, I'm not sure you need to have a lot of detail about the trauma, or you don't need to put it in every note. I mean, you just need to think about what do you really need to do your work and what do other clinicians really need to do their work if they are providing care or taking over care. So my advice is to err on the side of a little less detail if it's not needed. And then finally, respect. I think highlighting that individuality, again, putting one thing in your note, at least one thing in your note about this is what happened today, what the patient said, that really helps rather than kind of just cut and paste templated notes over and over. Just I have a list of references at the end, but this article that I mentioned at the bottom is a synthesis of a lot of information we gathered from both veterans and from clinicians. And I'll mention that we did our work on veterans. Veterans are older people, but they have a lot of similarities to other people in this country. So I do think that a lot of our work is very generalizable. And veterans aren't even that older anymore. I should take that back. The population's getting younger. A couple of words on challenging situations, and then I'll turn things over to Steve, and who may be able to help provide a little bit more information. So if you have a situation where you're really concerned about what goes into the note, one of the things you might want to do, and I know clinicians do this now, is to openly discuss with the patient what you document and reasons for including, so there aren't surprises. And the other thing that I think clinicians have done is sometimes actually sit down and write the note with the patient. So this can be, I mean, these are obviously not something you're going to do every time, but it is something that you might want to consider for certain circumstances. You might want to consider, and this obviously depends on the situation, asking a patient about his or her preferences for how much detail to include in a note. I don't know if it's so much about preferences, but about kind of having a dialogue about what goes into a note, what you feel you need to write, sometimes there may be a little leeway there. I think getting advice from colleagues or a supervisor before completing a note, if it's a particularly difficult situation, can be a really good idea, just another set of eyes. Again, considering which details to include in the note is also important. And you do want to keep in mind family members may access a patient's notes. And I have here a note about keeping psychotherapy notes. And so I'm talking about the formal HIPAA type definition of psychotherapy notes, which are not part of the record. I think it's a little unclear right now what the status of those will be over time. This also might be a situation where one of those few times where you might block access to a note. In general, my experience is that it should be really rare where you feel like you need to block some kind of access to a mental health note. I don't know if Steve has different thoughts about that. And finally, what can really help if you want the patient to potentially benefit from notes? Talk about the notes with the patient. And we did find in our study that orienting to patients to OpenNotes was associated with a 4 times increase in the odds of those patients actually reading their notes. And some health systems like Kaiser, I know, sends out notices after appointments saying, read your notes. I don't know if they do that with mental health, but they certainly have been doing that with other notes. All right, that's the end of my talk. Thanks very much.
Thank you so much, Dr. Dobshan. It's so helpful to hear about what's been going on in the VA, which has just been more historically very transparent within your electronic health record and patient portal for years, long before OpenNotes really became a thing, and clearly before this cures rule and information sharing rule that's going to affect April 5th has been in place, so many folks can learn from what you guys have been doing for so many years. I'm going to introduce our next presenter, Steve O'Neill, another Steve. Steve O'Neill is the OpenNotes specialist in behavioral and mental health and is faculty in the Center of Bioethics at Harvard Medical School. Steve was the social work manager for most of the behavioral health practices at Beth Israel Deaconess Medical Center for many years, and where he's also the associate director of ethics support service. Through his leadership, he started the first ever program in making behavioral health therapist notes readily available to patients through their personal computers in 2014. And he's going to share with us right now everything he has learned since then. Steve O'Neill.
Great. Thank you, Liz, and thank you, Steve, for your presentation. It's and some of what I will go through, I'm going to try to skip over my own redundant parts, that so we're not duplicating and we have enough time for questions and what have you. So I will talk a little bit about the experience of opening up notes in this. And what I'd like to do is kind of think about, for all of you clinicians, is to think about OpenNotes a little bit as another variation on narrative therapy. It's kind of a way to kind of capture behavioral health and mental illness, and really to kind of form more of a partnership with patients. And I will say, as a recurring theme, if you think about just the culture right now in our current culture with the pandemic going on and all that's been transpiring in the past week in DC, trust is a huge, huge issue for our entire culture, no matter where we're talking about. And if we can do anything to increase the trust that patients feel for us providers, I think that's a good thing. So that's a little of what OpenNotes is about, is to increase that culture of transparency and respect. So we start always with that question of what is best for the patient. And at Beth Israel Deaconess Medical Center, where I have been practicing many, many years, as part of a backdrop to that, I should mention that the very first electronic medical record in the world was started at Beth Israel back in 1986. Medical notes went online at our hospital. And all of our mental health notes went online in 1991. So we felt a little while later it was secure enough that we could begin to share notes. And for some of us, I and another colleague, we started a policy back better than 35 years ago. We would say to any of our patients who are coming in, if you want to see what we've written at any time, we're glad to show that to you. And that to me was kind of, it's not the same as the OpenNotes right now, but it was with patients being able to pull up the note to the computer, and if they wanted to see what they wrote, it was so helpful in getting them to settle down. And as the Associate Director of Ethics, when we started our ethics programs back better than 20 years ago, back in the 1990s, we started a policy that all of our ethics consult notes would be directly shared with the source patient involved and any involved family members that were involved in the consult. And these were oftentimes highly litigious situations or potentially litigious situations. In our hospital, we average our ethics support service averages for formal consults between 7 to 12 formal consultations per month, and a lot more informal, but the formal ones. And we would share the note in what oftentimes in the best practice, I would actually bring a draft of my note to the patient or their family so they could see whether I've captured their perspective, and then make sure I captured the perspective from the staff, and that would be the note that would go in. Our legal department was pretty wary of that when we started that. They were actually pretty nervous about it. But what they found was that we cut down on phone traffic to the legal department by better than 50% for the first 2 years that we started that program. And that, to me, was both in my own psychiatric practice, but also in the ethics service. Sharing notes, I found, was really a way to form better partnerships with patients. And at Beth Israel, we also are we think of ourselves as the transparency hospital. We started an apology and disclosure consortium many years ago that where we would acknowledge if we made mistakes. And we started a very open preventable harm initiative where we would put on our website, so you can go to Beth Israel Deaconess's website at any time, we put on our website any harms that have occurred to patients. And staff. It's both for patients and staff. And it's not just physical harm, it's also harm to patients' dignity or staff's dignity and respect as well. So we put that out there, and we had hoped that that would be a model that would be out there in that regard. So actually, we'll skip over this because Liz covered the Cures Act very well. The next slide. Okay, so the three questions we've had all along with all of this, and you can see this from Steve's data as well, is would OpenNotes help patients become more engaged in their care? Would OpenNotes be the straw that breaks the clinicians or the therapists back? And after a year, would patients and therapists want to continue? Bottom line is, yes, 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 in all of that. That's really what we found. So we started our rollout in our psychiatry department. The faculty decided they would do 10 patients a piece and ramp up. So they chose the patient that they thought would be the most beneficial and the least harmful. And then they've gotten more and more comfortable over time. In the social work department with our group, we gave staff a choice of either opting in fully and just opening up everybody, which is actually what most staff did. Just opened up their panels and fully from a point in time, not retroactive but prospective, from a certain date from the April 1st date, or they could do a ramp-up study if they ramp-up model if they preferred to. At this point, all outpatient and ambulatory therapists are open, within the departments. So we had some staff declined, and so there were a few that declined, but out of that, only 24 started and 28 out of 28 staff that were doing ambulatory. These are billed for a session, so these are only for billed for visits, so they are being billed as formal psychotherapy notes. And I think, again, we're doing this because a lot of Steve's, if you think of the population that Steve's talking about, it is generalizable, the VA system is, but our patient population is also very generalizable as well. So this includes our community health centers, as well as the outpatient psychiatry, in our therapists within primary care, within oncology, all the various services that were out there. Started with 440 patients at the start, and then we've now graduated. I think it's actually closer to about 5,000 patients who are currently participating in OpenNotes at the hospital. Common concerns. So as we've heard, everyone worries that it's going to cause harm, and one of the staff worry that it's going to have an increased, pressure and work burden. They're going to feel a sense of pressure to get their notes done in a timely way. And I will say, as a manager, to me, I actually appreciated the pressure of them getting their notes done, because some of my more delinquent staff became much better at getting their notes done in a timely fashion. And part of it is they didn't want to feel embarrassed in explaining to a patient why was their note not in there. So. Next slide. Folks always worried about whether patients would misunderstand notes, so they were concerned about that. But next slide. On the other hand, I'm hopeful that the OpenNotes may actually enhance the therapy process and promote greater communication and understanding on both sides. So we think about it as really, it's an opportunity for grist for the mill, for the therapeutic mill, if you will, and really a way to connect with patients and to strengthen the therapeutic alliance. That's certainly been my view, and I think it's the view of most of my colleagues at the hospital. All of our staff were worried that they were going to have to re-language notes and processing the notes when, they were particularly worried, will they be angry about certain content, right? And you heard that from Steve's presentation as well. So we're going to have to double chart. We're going to have to change our notes. We're going to have to start doing more process recordings, all those kinds of stuff, side notes, that kind of thing. And people were putting in much. But now what we found was basically the staff did not have to do that. They did not have to relanguage it. They did form a subcommittee to kind of think about putting together a thesaurus of words, and they actually found they didn't need to do that. They did have to explain to patients sometimes about, for instance, why do you put a mental status exam in every note? And why do you say a comment about my lethality, whether I'm suicidal or homicidal or whatever, in every note? So, there are certain things where we would certainly explain to patients about, what are the necessary professional requirements that we have that we've got to document in there. And there was concern about, severe mental illness, especially psychosis and paranoia. But I will say staff learned, and they knew this from myself and that other colleague, our patients with severe mental illness, and particularly our psychotic patients, when we showed them the notes, and this is again the hard copy of the notes that OpenNotes through their computer, but we started doing that, we found those patients tended to settle in more to the therapy. They stayed because they felt like, okay, you're not hiding something from me, which is a common concern. So we developed an FAQs and scripts both for the patient population, for the staff population, and particularly, by the way, for your front desk staff, the receptionists, who oftentimes get bombarded with questions that patients in the waiting room will ask them that they don't ask the clinicians in the back rooms. So we found we had to do some work around that. All of those are on our the OpenNotes mental health OpenNotes website and are there for anybody to kind of take if they're useful at all. So we had to anticipate all that. And with the thesaurus that we thought was there, we didn't really need to change that. So what did we find? Patients were pleased, right? They were not scared. They read their notes, they reported important benefits, and they shared their notes, and they wanted their notes. So the adverse effects that patients oftentimes worried about more, particularly in a system like ours, where it's a very interdisciplinary system, was that they were worried about what other providers would have access to the notes. So it's a little bit more about a privacy concern. They didn't want people who were more peripheral to their care to see the notes about that. But in our system, we can't segregate those notes. Our notes are part of a whole system in that way. But what was most important, and particularly I think for those patients that are just beginning therapy and you're beginning a therapeutic alliance, seeing a concordance between what the clinician says in the session and what's written in the note was really what strengthened the alliance and really, or confirmed the alliance. It was already a good existing therapeutic alliance. That's what patients wanted to see the most. And it's more and more when you hear about this on the medical as well as the mental health side, patients feel ambushed if they start to see stuff that they was like, wait a minute, that didn't happen. So, or that wasn't talked about. So in our study as well, one of the things we found in our study was that we found that our staff, patient and patients never talked about reading their notes with each other. The clinicians were all waiting for patients to bring it up, and the patients were all waiting for the clinicians to bring it up. So we encourage you to think about bringing it up with patients, right? And most of us, I was trained in a very traditional analytic psychodynamic model, and that's what a lot of our staff are trained in. We wait for patients to bring things up, and so people don't bring it up. And this notion, I would say bring it up and ask about what the experience was like. So what we found was 18% of patients shared their notes with family, compared to 20 to 42% on the medical side. I would say that's that really is key, and that was there. And patients stopped reading their notes after a while because a lot of our notes, quite frankly, are a bit redundant. So they didn't need to kind of see them after time. There's a lot of redundancy. They read them less often. All systems have these nightmare patients that they worry about in their practices. And I would say basically those are always labor-intensive patients. Next slide. They're labor-intensive patients, and there's a contagiousness of staff anxiety. And I've heard this from systems across the country, all through the country, about that. The people worry about that. Those are labor-intensive patients. To me, the question is, does the OpenNotes, does it have the potential to limit some of the labor intensity? And my experience has been it really has been. All right, so I'm going to just give one example of here, and I'm going to skip the other ones that I have. I'll tell you a patient I had in I had a long-term therapy group with probably the average length of time in the group was around 15 to 20 years. And all of my patients were opened up, and she would read her notes, and then she would get fully regressed and not be able to go out of the house for days until she came for her next therapy session. It was a very negative experience of her reading the notes. And when she read her notes, she viewed that everything I wrote was just a horrible, that I was documenting horrible things about her, that she was a horrible person. When the staff or the patients, the other patient in the group said, well, geez, can we see the note? She brought in some of the notes. We pulled up notes in the session, and the other patients in the group, they did this phenomenal work with her to say how distorted she was about the note, because it really talked about her resilience and how, this is someone who struggles with everything and sees everything in the negative. And so when the other patients really could reinforce that, it was so remarkably helpful. And now, some years later, that same patient could read her notes without getting regressed. And it really was so helpful. I would say that's a hallmark. And I'll mention just one other patient. It took him 2.5 years to read his first note. And when he read his first note, he hadn't wanted it because he was afraid it would just confirm that he was a horrible person. Go to the next slide, Amanda. That it would confirm he was a horrible person. It took him 2.5 years, and when he finally read it, it confirmed that he was really, a very resilient person. And we talked about his strengths. But in that note, it was helpful for him to see it, but it just took him a long time. So we think about OpenNotes as one more tool in your bag of tricks, and that's really about it. So next slide. So the couple said, I'll just go through this. That was this patient here. His quote was, "I'd be petrified to look." And I'm not going to go back to the other ones that I had there. But these are examples of this. OpenNotes it's one more tool for you to think about. And it isn't for everybody. That looking under the hood that's here, it's just upset. There are some patients, particularly our obsessive compulsive patients, who ruminate about stuff, who in fact actually sometimes it might not be so helpful for them to see the note. So you should think about who it's going to be helpful for and who it's not. But some of our obsessive compulsive patients have said, I don't want it, just like going to the mechanic. I'm not going to look under the hood. I'd rather not. And so that's fine. It's really, again, it's not for everybody, but it can be for most in that regard. So bottom line is 80%, almost all the patients want to continue, and said it would affect their choice of future clinicians as well. Next slide. Right. And I would say, one other thing, and I'm going to wrap up on this actually, is that we use this 70-30 rule that about, when you think about patients hearing bad news, particularly a bad diagnosis, a terminal diagnosis, there are a lot of studies on the oncology realm that talk about how little patients can hear. And what I would say, the same thing is true in mental health. So if we're delivering this 70% of you're delivering bad news to a patient and they don't remember any more than 20 to 30% of what you tell them, and they remember 70% of it's good news, right, in that way, then we flip that. Why would that not be true with patients who are filtering things with anxiety, with depression, etc.? And so for them being able to see the note really is in fact actually very informative and clarifying for them about things that they need to do. I've had a lot of my patients would actually post their notes in their homes to see and remind them of what they're supposed to be working on. And so it's again become a real nice tool to kind of complement the therapeutic work. Next slide. Next slide. Okay. And I would say, by the way, I would encourage you to think about including mental health patients in opening notes, just like medical patients. I think we are contributing unwittingly to stigmatizing patients with mental illness by saying they can't handle it, when in fact actually the data shows they can. So I'll stop there and thank you very much.
That was awesome. Thank you so much, Steve O'Neill. So we're switching into the Q&A part of the webinar. Joining us is Deb Walkentime, who's going to be reading the questions from the Q&A section, as well as Dr. Kate DeRoche, who's the executive director of OpenNotes. She'll be joining us as well to answer some questions. I did want to let you guys know before we get to Q&A that we have a number of other webinars coming up in the next couple of weeks and months on pediatrics, oncology notes, inpatient notes. So if you're on a mailing list, you'll get updates about those. All right, we're transitioning to Q&A, and Deb, tell us what you see in the chat area or in the poll question area.
So there are 3 questions that I connect to the new federal rules. So should I read those 3 together and then you can kind of go from there?
Sounds good.
Can you summarize the Cures Act components for mental health clinicians? And then the 2 related, if a patient has a history of violence, or their feelings would be, has a history of violence or their feelings would be severely hurt, looking at their notes, would that fall under the definition of harm, allowing the note to be excluded from the record? And can you define the difference between a counseling note and a psychotherapy note? Did you get those 3?
Maybe start with the first one again.
So Steve, do you want to give an overview of the Cures Act as it relates to mental health notes? One of the Steves, whoever feels.
Sure. Well, I would say, so I'll try to tackle it a little bit. So I would say there's a little bit of confusion, and I would actually, between all the various systems and the interpretation about some of this. But the general sense has been that that we're not supposed to exclude groups of patients per se, but you can exclude patients on a case-by-case basis. So you can't say all psychiatric patients should be excluded from opening up notes, but you could exclude certain patients on an individual case-by-case basis. And that's a little how many of the systems are just opening it up in that regard. And I would also say that some systems that, it looks like there was an out where it says psychotherapy notes are excluded, but that, then it gets into the definitions of what's a psychotherapy note and all of that. And that's a little something where I encourage all of you to kind of get to your folks in your legal department and your information management department to find out your system's clarification about those particular rules. Because what I'm hearing across the country is that it varies from system to system quite a bit, and there's a bit of confusion about that in that regard. But many systems, because of expediency, are simply saying, well, if we're opening up all the medical side and we've got some pretty good data here on the mental health side, why not just open everything up? And so that's actually what's happening, is that there's a whole groundswell to just open it up in that regard. So I don't know if my colleagues have anything else to add about that.
Hold on, I think I muted you, Steve. Let's see. Unmuting Steve Dabsha right now, and go.
Thank you. I know I was drinking coffee, probably making noise. Anyway, I just wanted to echo that. I think the specific circumstances that you can block for, my understanding, is completely at this point. And so I like the idea of connecting with your institution to make sure you're at least all using the same types of standards. Getting back to maybe the second question, if a patient gets upset, again, we found probably a good third, maybe even a little more, reported some upset from the notes, but most people want to keep seeing the notes. It was really a very small number, 10%, who reported frequent upset. So I don't think that, I can't imagine the standard would be, if you're just going to get some upset, that you should be blocked.
I think, and my understanding is that the harm has to be physical harm. So psychological distress is not part of the harm definition. Is that right, Steve or Steve?
I've seen different interpretations about that. Both.
Okay.
It generally starts with the physical harm is really what it is, but the worry is that the emotional harm could lead to physical harm or something. So that's another aspect of it. And I would also add that, just as Steve just mentioned about, particularly patients in the VA with PTSD, who then sometimes would read the note and get more upset. We found that, I've certainly seen that anecdotally. We haven't studied this, at least on our end, but I hear this pretty regularly a lot of our clinicians who are working with, for instance, rape trauma patients, they put in a lot more lurid detail than probably is necessary. So then the patient then reads the note, or it's domestic violence patient or whatever, and when they read the note, it recapitulates the experience, and so it re-traumatizes them in a way. And that's a little what's going on there, I think, in terms of the psychodynamics. And that's something just prepare patients for in terms of when they might choose to read a note. So
a question for Steve Dobsha. Those 46% of clinicians would be pleased if OpenNotes were discontinued. What is your theory of how much of that desire is driven by the extra time, energy it takes to write the OpenNotes versus more closed notes? And another person had a related question. I'm curious if OpenNotes causes providers to spend more time on writing the note. The documentation process is already very burdensome, contributes to burnout. Can you suggest ways to streamline and reduce rather than increase the time a provider spends on documentation?
Yeah, I actually think the additional documentation burden is pretty minimal. And Steve did a much better job of talking about this. It's a couple of words here and there. It's not really, and I mentioned acronyms, but as I've thought about it, acronyms isn't really an issue either. So I don't think the notes take that much longer to write. And I think that's been our experience. I think it's more you have to be thinking about it, thinking about what you write, and maybe a little bit about how you write, maybe adding a few more details. But it's not there. I think the extra time may come in when a patient wants to talk to you about it, and I think that's probably one of the barriers to why clinicians don't bring it up. So one barrier is they might worry about a bad outcome. Maybe they're nervous about, what the patient sees, but another one is that they're probably worried that the patient's going to start talking about it in session. And I think you'd have to handle that the way you handle any new issue that comes up in a session, right? Sometimes you might want to dive in and you may end up with a better patient alliance because of it. Because you've had that discussion and you've explained what's going on. Other times it may be distracting you from other types of activities. But writing the note doesn't really take much more time.
Yeah, I would add on the writing the note part. Actually, our staff found it was a little less of a work burden than it was expected. An average progress note takes around in our system takes 7 to 9 minutes to do, and an intake evaluation takes between 45 and 52 minutes. That's what it was. And I found some of my staff that were struggling with the open notes. One of them was her average progress note was taking her 28 minutes. To do, and so she was writing way too much. I mean, that was, and so her efficiency got much better because she realized she didn't even need to do all the notes, and she was writing things in there all the time because she was afraid she was going to forget stuff from session to session. And so, she just keeps side notes now is what she does, and puts in the basic stuff that she needs to put in there. So
yeah, notes have been increasing in size for ever since we got our electronic medical record here in the VA since 1998. The amount of time clinicians spend in it anyway, the length, it's just tremendous how they've increased. And I don't think OpenNotes is really a big factor.
A question for Dr. Dobsha. Any sense of the impact of OpenNotes on adherence to big league psychiatric meds?
Big league psychiatric med. Not quite sure what that means. We don't have any. What's that?
Psychiatric meds in general, let's say.
Right. We don't have any data, and I have to say I'm moving off into different areas. And if anybody who works in the VA wants to reach out, I'd be happy to talk to them about future projects. But as far as I know, no one's looked at that in the VA system. I don't know how you'd study it, because the other thing is that VA OpenNotes just went boom, big bang across the VA. So it's hard to, it's a little bit hard to tell. You could look for associations between adherence to medications and so forth. And we did find in our little study, or relatively small study, that patients reported impacts on their adherence, but we didn't look at the meds in the record.
How do you deal with intake evaluation notes where the assessment may still be ongoing, diagnostic impressions are preliminary, or intakes a trainee conducts where they need to consult with a supervisor before giving feedback to a patient, but a patient may get to prematurely see that intake note?
Is that for me or for Steve?
either way. Go ahead, Steve, if you want.
No, you go ahead.
All right. So I think that generally when you're uncertain about something, you put those things in. But mostly, I would say probably the biggest increase of staff, if there's any change, people use a lot more quotations. They put in a lot more things that are directly from the patient, I would say, in that regard. And if they put down, their diagnostic impressions, if you're putting out something that's a rule in or rule out kind of a condition, you are putting in your diagnostic impressions. We should not be, turning over your professional obligations to patients. They should not be able to choose what you put in the note in that regard. That is still your domain, right? There is patient autonomy, but there is professional autonomy as well. And you've got certain obligations to put that in there. It's more about explaining that to folks. And as for our trainees, they're obligated to say, at the beginning of the therapeutic relationship in all, I believe it's in all states, that they are supposed to inform someone that they're a trainee and that they are under supervision. And so that should be something that is part of the initial informed consent in a discussion right off the bat. So that's what I would say. Liz?
I'm jumping in to let you know that we're at time. There are more questions here than we have time to answer today. So I want to make sure, invite everyone who's still logged in to our office hours next week, which is on Tuesday, January 19th. I just put the registration link there with information in the chat area. If you join us, it's just an open discussion with Dr. Dobshaw, Steve O'Neill, Director of OpenNotes, Kate DeRoche will be there answering some of your policy questions, the whole crew, and would love for you to join us. Unless anyone else has anything to say, wave your hand. I want to say thank you for everyone for showing up today and attending this webinar. You will receive an email in about a week with a link to the recording of the session, links to the slides, and any other resources either of the Steves mentioned in today's presentation. And thanks to them both for sharing their research and real-world experiences with sharing mental health notes with patients. Thank you, everybody.